For the meeting to be broadcast. We will begin in about 30 seconds to a minute. Thank you. Good afternoon. Good afternoon to you all. A very warm welcome to this ad hoc committee on COVID-19 of the Western Cape Provincial Parliament. My name is Mireille Wenger and I'm the chairperson of the ad hoc committee. We would like to welcome committee members of HASA, which is the Hospital Association of South Africa, as well as the chairpersons of respective hospital facility boards in the Western Cape, and our COVID-19 survivors who will be sharing their stories with us today. We'd also like to make a warm welcome to members of the committee, as well as members of the public in attendance, some NGOs who are joining us today, as well as to the public that are tuning in on YouTube. We'd also like to welcome our procedural officers, Ms. Klutter and Ms. Adams. I'm going to start with some apologies. I have received an apology from Ms. Sandra Bradell from the Alexandra Hospital Facility Board, as well as Ms. Vanessa Buerta, who's the chairperson of the Prince Albert Hospital Facility Board, and I believe that Ms. Hoos will be attending in her place. We also have an apology from Honourable Bosman. Honourable Mackenzie will be standing in for him today, as well as an apology from Honourable Syed. Are there any further apologies, please? All right, if there are no further apologies, I'm going to start off with the rules of engagement for our virtual meetings. All participants were muted at the start of this meeting to avoid background noises. I ask that if there are any points of order from members to please use the raise your hand function or otherwise to indicate so in the chat function. The chat function can also be used for any technical problems, but it should be kept free of chitter-chatter and only be used for points of order or if there are technical issues. We ask that all video and audio be switched off to improve the quality of the connection. However, if a person is speaking or making a presentation, of course, they would need to use their microphone and use their video. We do ask that participants turn off their microphones once they have concluded their inputs. For those that are sharing presentations, once the presentation is concluded, if you would please unshare. With that out the way, I'm very happy to say that this is the first meeting of this ad hoc in our public participation phase. So the Constitution of the Republic says that provincial legislatures must facilitate public involvement in its committees. So today is our attempt to provide for those sections in the Constitution, and we kick that off today in line with the themes that the committee determined in April already. So today is health responses, and we will be hearing from the private hospital sector. We will be hearing from volunteers from hospital facility boards, as well as COVID survivors. So today we will be listening to their stories and their experiences. The agenda for today will proceed as follows. We will first have a presentation from HASA and then a Q&A from members. That will take up the first hour of our meeting. Thereafter, we will have inputs from the Hospital Facility Board volunteers, as well as the COVID survivors, and we will have a Q&A to both thereafter, and that will take up the remaining 2 hours of our meeting. So on that note, I will then say a very warm welcome to HASA and all the representatives here from the various hospitals represented. Thank you very much for the work that you do, and your responses are critical to the overall COVID response. So we're very happy to have you here. Thank you for coming to talk to us on the readiness and responses of private hospitals in the Western Cape. We will also be hearing a little bit about your bed capacities and your cooperation with the Provincial Department of Health. I believe that the briefing will be led by Dr. Biren Valodia, who's the chairperson of the HASA board. So good afternoon, sir. A very warm welcome. If you would like to introduce yourself and your team, please.
Thank you very much for having us this afternoon. I really appreciate that. So if I may start, Chairperson, thank you. Good afternoon, Honourable Speaker, Honourable Premier and members of the Provincial Cabinet and Legislature with us today, Honourable leaders of political parties, Honourable Chair of this ad hoc committee, chairs of the parliamentary committees present, acknowledging the Director General of the Western Cape and any and all civil society, community and religious leaders with us today, special guests. Hopefully, having observed all protocols, please allow me to introduce myself. My name is Biren Valodia and I'm the Chair of the Hospital Association of South Africa, and I'm also the Chief Marketing Officer of Mediclinic Southern Africa. Today, we have a number of hospital groups with us present on this call, and will also participate later. They are Life Healthcare, Clinic Holdings, Lenmed, Mediclinic, Netcare, and the National Hospital Network known as NHN. Before we proceed, on behalf of the Hospital Association of South Africa, I wish to offer our deepest and most profound thanks to every healthcare worker standing in the front line in the battle against COVID-19. There are no words to adequately convey how important you are to our country, nor can we ever hope to measure your sacrifice and your contribution. We are also thankful for this opportunity to share with you some of our work we, as the private hospital sector, have done to contribute to the national pandemic response, or as the Minister of Health puts it, to fighting this war against COVID. We will shortly share with you what we hope are useful insights, whereafter my colleagues from the various hospital groups look forward to further discussion with you for the time that we have left. We are mindful of the severe time constraints on yourself and admit that we too are under severe pressure. We will therefore move through the slides that we have prepared quite quickly and as fast as possible. Chair, with your permission, I'm now going to share our presentation on the screen.
Thank you, Dr. Biren. Please do proceed, and we echo your thanks to our frontline workers. Thank you.
Okay, so in the invitation we received, we noted the following ground to be covered: readiness and responsiveness of the private hospitals in the Western Cape to COVID-19, intermediate and acute bed capacity in the Western Cape for COVID-19 patients, testing data and challenges, cooperation with the Department of Health at the provincial level, and the new normal health system post the peak. We feel confident in addressing most of these, but regretfully cannot contribute much to the conversation or discussion on testing data and challenges, as this subject falls outside the ambit of private hospitals. In our discussion today, we propose to cover the following ground: a few notes about us, a very brief but necessary context, steps the private hospitals have undertaken both within their facilities and externally in the healthcare system. In particular, we will focus on our collaboration with the Western Cape Department of Health. And finally, we will offer some thoughts on learning on the future. To begin, these are worrying and uncertain times, and we must ask ourselves, are we doing everything we can to protect our people? The sector that I represent has for months been singularly devoted to making sure we can answer the question positively. When I refer to the private hospital sector that I represent, I am not referring only to members of the Hospital Association of South Africa, as displayed on the screen before you, who constitute the majority of the private hospital sector. I'm in fact speaking about all private hospitals, HASA members and non-HASA members that have come together under the banner of the Health Facilities Response Workstream of the Business for South Africa initiative. The workstream meets regularly, initially several times a week, to discuss preparedness for the pandemic. Various critical engagements with the Provincial and National Department of Health, engagements with the other health role players, all with a view to making sure we are doing all we can for everyone in this country. The workstream has contributed significantly to Business Unity South Africa in other various discussions, including the procurement of protective wear, equipment, machines, communication, and awareness campaigns, and a range of other matters. The observations that follow are therefore from all private hospitals and not only members of the Hospital Association of South Africa. It is important that we recognize the context in which the work we will discuss took place and the pressure that the work was performed under. As you can see from the slide, it took just over a month to move from a pandemic alert from the World Health Organization to recording 100 deaths in South Africa. It took just 78 days from recording our first 100 deaths to today's number in excess of 5,300. It was far less than a month that we moved from our first confirmed case to the travel ban and the first social tightening. Where we end up is anyone's guess, but the most important takeaway is this: COVID-19 preparedness throughout the country, in both the public and the private sectors, was undertaken with great speed, under great pressure, and without any prior learning and experience. We did not have the luxury of weeks and months to prepare our complex and vast system. In these circumstances, what our country has achieved, in our opinion, is something to be proud of. To demonstrate the various aspects of early preparedness in a simple manner as possible, we describe 4 buckets of activity that private hospitals embarked on and that are described further in the next slide. Firstly, systemic changes were necessary to enable the flexibility necessary to be responsive. So we approached the appropriate ministers to temporarily relax competition rules and licensing regulations. We are grateful that Minister Patel and Minister Mkhize responded quickly. Secondly, it was important to collaborate with officials leading provincial responses. This included regional command councils and department meetings, various information sharing opportunities, the Bed Bureau. In terms of internal preparedness and clinical responses were also needed very quickly. In many instances, elective surgeries were put on hold. Internal preparedness included things like disaster planning, command structures, occupational health, including separation of COVID and non-COVID zones, reporting systems, awareness campaigns. And in terms of clinical, staff training, patient flow treatment areas, additional staff in terms of volunteers or upskilling, surge planning, equipment audits, and procurement. As you can see on this slide, many of the actions just described were undertaken very early in the pandemic. For instance, the 2 important requests to the Minister of Health and the Competition Commission were both made in mid-March already, when it was apparent that the virus would spread very quickly, necessitating a lockdown, and the healthcare system would require flexibility in order to respond adequately. Also, you'll see in early April, the private hospitals engaged with the South African Nursing Council to enable temporary restoration of nurses who wish to volunteer for the pandemic response. And also early on, as the scale of the pandemic became more evident, so requests for information poured into private hospitals, to which we responded. From the National Institute of Communicable Diseases for PUI, patients under investigation, as well as case statistics. from the National Department of Health for staff resource numbers, bed and equipment, from the Department of Trade and Industry for consolidated ventilators and aesthetic machines, CPAPs per facility statistics. Simultaneously, the private hospitals received requests for engagement from provincial departments, various committees, and a range of other institutions, which private hospitals executives attended without exception to discuss bed numbers and a range of other matters. Aside from the external activities just described, private hospitals needed to attend to internal matters. In this somewhat busy slide, we have tried to summarize the many internal activities that made up the initial preparedness phase of the pandemic response. In short, the facilities needed to study and incorporate the various guidelines issued by the Department of Health and the National Institute of Communicable Diseases, while studying advisories from the World Health Organization and engaging with medical schemes on specific issues they wanted to discuss. Private hospitals benefited tremendously from the various inputs, advice, universities, and through documentation, discussions, and engagements with experts from various specialities. The clinical guidelines issued by the Department of Health were greatly appreciated and guided not only private hospitals, but also medical specialists, general practitioners, and the role players throughout the healthcare system. It was also necessary to ensure sufficient PPE and equipment was available. As you're aware, this in itself is complex and a difficult issue. Private hospitals, in addition, had to reconfigure their facilities to comply with various regulations by separating for COVID patients and non-COVID patients. It was important to arrange bed capacities and theatre operations to comply with social distancing. Finally, hospitals needed to set up a dynamic modeling operations of their own to anticipate logistical and capacity demands and to ensure they were and remain prepared for the surge. With regards to the partnership between the private hospitals and the Western Cape Department of Health, we offer the representation of the main outcomes of the relationship between the Western Cape Department of Health and the private hospital interactions. For now, it is important to note that much of the work completed between the private hospitals and the Department of Health has become an example for other provinces. For example, the recently concluded service level agreement that we will shortly discuss serves as a template that other departments are using, so speeding up their own processes. In this sense, the Western Cape can be said to have made a significant, though not easily seen, contribution to the rest of the country in their own pandemic response. We will go into each in more detail in the next slide. We note with great appreciation all the Department of Health officials who have in so many respects ensured the following account of interventions is possible. Private hospitals joined the Western Cape Silver Command in April to contribute to the provincial pandemic response under the leadership of the Western Cape Department of Health. One of my colleagues will talk to this in a little bit more detail as a member of the Command Centre. Secondly, the Western Cape Department of Health Learning Collaborative was established to enable learning from the pandemic and is where the private hospital groups have presented case studies and where academic experts participate in the process. Private hospitals participate in the Western Cape's Joint Operational Committee that was established to allow for discussions on various operational matters within the healthcare sector. In July, the parties entered into a service level agreement that establishes a mechanism for the use of private hospital beds to treat public sector patients and enables the sharing of available resources for the beneficial treatment of COVID-19 patients across both sectors. Here too, a colleague of mine will talk about in a little bit more detail towards the end of our presentation. The private hospitals have developed a dynamic online platform that provides twice per day updated and consolidated database of available demarcated COVID beds and ventilators. With bed numbers changing consistently during the expanding surge, this tool promises to benefit the pandemic response greatly. In closing, we note several successes. First, we have experienced strong leadership of the pandemic response. This applies both nationally and here in the Western Cape. The strong leadership has come from a number of officials in both the administrative and clinical roles. We are grateful for them, but we have also experienced a gratifying level of collaboration and dialogue. These qualities combined, we believe, made for effective operations. HALSA has long advocated for collaboration and strong partnerships, so we are particularly thankful to see again just what we are capable of when we work together. On the other hand, amongst the challenges is a serious liquidity crunch. Many facilities scaled back on elective surgeries and treatments to be ready for the pandemic. They have not yet seen a surge, and so they remain relatively empty with fixed overhead and little revenue. What has exacerbated the situation was that a number of private hospitals were owed payments by certain regulatory institutions for services rendered to patients prior to the pandemic. HALSA has engaged with these institutions, and hopefully there will be a resolution soon that will enable smaller and independent hospitals to keep their doors open and make it easier for all hospitals to continue to play a crucial role in the pandemic response. An additional problem that predates the pandemic is the nurse shortage. While this is a complex issue and matter to go into here, the pandemic has demonstrated the critical need to train more nurses in general, but to take steps to increase our numbers of nurses, particularly with specialist skills. We are, of course, happy to discuss any remaining matters noted on the slide if we have time after the presentation. At the beginning of the pandemic, Dr. Anban Pillay, the Acting Director General, pointed out that the private hospitals were fully behind the pandemic response. In June, Dr. Nicholas Crisp made the same point. So we were then, we are now, and will continue to completely be supportive of the pandemic response under the leadership of the provincial premiers, the MECs for health, the National Minister of Health, and the President. We will continue to do all we can. When it is time to contemplate the post-COVID world, we will need to evaluate properly where we stand from all perspectives, including the national economic position and our prospects. Only then will we have a sense of the work to be done and what available resources and capabilities we have for that work. But what will not change, however, is the requirement to make sure that our people have access to quality health. We remain committed to defining how to deliver on this requirement. For now, however, we should entirely be focused on getting through the COVID and saving as many lives as possible. I thank you. Chair, if I may now unshare my screen.
Thank you very much.
I would like to call upon two of our colleagues to talk to the two specific points I've just referred to earlier, and which is specifically relevant for the Western Cape. So the two colleagues are, the first is Andre Viljoen, he's from Mediclinic, who represents the whole industry on the Western Cape Silver Command Center to share some of his thoughts and experiences with us. And then thereafter, I'd like to call upon Melanie da Costa. She's from Netcare and a board member of HALSA, who was one of the key leads in the development of the SLA with the Western Cape Department of Health, to share some of her thoughts and insights. Whereafter we will take any questions you have with the assistance of all my colleagues from the various hospital groups. I thank you.
Thank you very much, Dr. Valodia. If your colleagues would proceed, please. Thank you.
Thank you very much. Thank you, Biren. Thank you, Chair. I'm Andre Viljoen, as Biren mentioned, and I was asked just to reflect on the interaction that we've experienced as part of the Silver Command structure for the Western Cape Department of Health. So my personal experience has been that the Western Cape Department of Health is extremely well organized, proactive and decisive in planning and execution, while still requesting and listening to input from various stakeholders. They engaged with the private hospitals already the first time on the 18th of March, shortly after President Ramaphosa declared the national state of disaster. And since then, we have been included in weekly, recently now bi-weekly, Silver Command feedback meetings chaired by Dr. Sadiq Karim. There's also been a WhatsApp group established early, and there's been much interaction and sharing of ideas on that platform. The purpose of these meetings has been to keep all stakeholders informed of all aspects of planning, execution, and challenges that have been experienced relating to COVID-19 pandemic in the broader Western Cape province. Specific feedback items shared has been regular updates from the Gold Command structure, chaired by via Dr. Kluti, which highlighted the latest case numbers in the different districts, planning and implementing of the field hospitals, hotspot containment strategies, health platform responses, including the testing challenges that there were and how this was addressed, staffing matters, messaging and communications to staff and the broader public. All in all, it has been a very positive experience for myself and my colleagues, and I'm very proud of what the Western Cape Department of Health has done and achieved during this time. I thank you.
Thank you very much for those lovely words. Ma'am, over to you. Sorry, ma'am, you're on mute.
Oops, sorry about that.
So apparently the phrase of the year, you're on mute.
Yes. So good afternoon to all, and thank you, Honourable Speaker and Honourable members for the opportunity to engage with you. So I'm just going to spend 2 odd minutes just talking about the service level agreement. And, just to reiterate what Andre Viljoen said, we have found that the Western Cape have been very proactive in engaging with the private sector, including in the early phases of the pandemic. So the private sector were consulted, as Andre Viljoen mentioned, in early March, first with an invitation to join the COVID-19 Silver Command structures. And then in April, we started engaging proactively on contracting. So on contracting, there have been 2 processes. So the first is at a national level. So at a national level, private hospitals have supported the Department of Health in informing the tariffs that they would then prescribe. The prescribed tariffs that each province in the country would use as a maximum to purchase services from the private sector for state COVID-19 patients. The second has been a process of agreeing SLAs. Now, the SLA effectively determines the contractual relationship that governs, or the contractual arrangements that govern the relationship between the various provinces and the private sector. And as mentioned, this needed to be done at a provincial level rather than at a national level. So on pricing, on the 2nd of June 2020, the National Department of Health published what they deemed the prescribed per diem tariff. So it was a rate per day that would be applicable for all of the various health elements for a patient, a state COVID-19 patient that had been admitted into a private facility. So even though that was the 2nd of June, there was still an element of work to be done. And it was only on the 2nd of July that we saw the pricing issues all being finalized. So what the National Department of Health needed to do was to determine the rates that would be charged if a state COVID-19 patient complicated in the private sector. But notwithstanding the fact that this was only arrived at in July, we started seeing Western Cape patients in June showing bona fides and just reflected the level of trust between the private providers and the province. So on the Western Cape SLA, once again, the team have been so professional and we've been consulted every step of the way. So compliments to the Western Cape team. The SLA covers important areas, and those important areas include a digital tool to show the available beds in the private sector, but then there was a very clear referral pathway. So one is to identify where might one find a critical care bed in the private sector. The other is what is that referral process. So, each private hospital and hospital group would have what we'd call a JOC. It's a joint operating center, as has the Western Cape, and it would be a function of how would those two JOCs engage. And this engagement is important to validate the availability of the bed, of the clinician, of oxygen, etc. The SLA went into detail with respect to the fact that a patient could only be absorbed if an authorization number was issued by the state and what documents would follow with the patient. It was also pretty prescriptive on the use of an administrator to administer the claim, just as any medical scheme would. And furthermore, the SLA went into some detail as to what process to follow if a non-medical aid member or a state patient presented at an emergency department of a private facility rather than at a state facility. So it was very helpful to iron out all of the potential permutations and to ensure that we were all aligned on the process to follow. So the SLA has given us all an opportunity to engage and be proactive in a form of private-public partnership. It is, as I mentioned, on a cost recovery basis, and furthermore, it is also on an any willing provider basis. But all private hospitals have embraced the engagement, and we have a good contingency of independent doctors that have signed up to offer their services. So the first public patient was transferred in the Western Cape, and it was exactly a month ago today, the 22nd of June. To date, we've only seen a handful of transfers coming through to the private sector. You would well know since early July, the pressure on the system has alleviated somewhat, but nonetheless, we stand ready and at your side to deal with this pandemic. Thank you for the opportunity to give you that summary and happy to field questions if needed.
Thank you very much for those inputs. We're very grateful for them. Dr. Belodia, are there any further inputs?
No, no direct inputs, but the team would be happy to take any questions that might arise.
Super, thank you very much. Okay, we'll then move on to a round of questions from the members. How we work, just so that you're prepared, is we give each political party represented on the committee 3 minutes to make some comments and to pose some questions. So we will then go by party, and that representative or representatives will then pose questions. And once we've given each party an opportunity to pose a question, I'll then hand over to you to answer the questions, or if you prefer to delegate that to one of your team members, I'll leave that entirely up to you. Is that in order?
Very happy with that. Thank you very much.
Okay. Perfect. Then, as usual, we will start with the DA. Are there any questions from the DA?
Yes, Chairperson.
Thank you. Honourable Philander will then be asking the questions. Honourable Philander, please, over to you.
Thank you very much, Chairperson. First of all, thank you to Dr. Belodia, Mr. Viljoen and Mr. Costa for the presentations made. My first question would be, Chairperson, have the private hospitals experienced delays in testing for COVID-19 patients? And then, Chairperson, based on the presentation that was made, it made, in terms of the licenses, the suspension thereof, I would like to get a better understanding, Chairperson, what that process has entailed. I believe Mr. Costa might have made mention in terms of the service level agreement, but what did the suspension of the 158 and 187 licenses, especially to the categorization of beds in the province, exactly entail? And then, Chairperson, on additional health resources, what was the response in the private sector regarding the engagements with the SA Nursing Council in April this year? And what is or what was the most prominent resources that was shared from private to public sector during this pandemic? And then, Chairperson, if you would allow, since I'm talking about nurses, it was also pointed out that one of the challenges were the shortage of nurses that needed to be addressed. And how did the private sector deal with that challenge? I am covered in terms of collaboration with the province. In terms of preparedness, the capacity building efforts, Chairperson, has there been any noticeable success or challenges pertaining to this particular agreement up to date? And also, Chairperson, how are scheduled and emergency procedures addressed in the Western Cape? My last question for now, Chairperson, how effective is the Bed Bureau initiative in the public and the health sector? And what is the role explicitly for the private sector in this instance? That covers my questions for now, Chairperson.
Thank you very much, Honourable Philander, for those questions. We then move over to the ANC. Are there any questions from the ANC? Are there any questions from the ANC representatives on the committee?
Chairperson.
Honourable Dugmore? Yes.
Yeah. Chairperson, thank you very much, and thank you for the presentations. Could we just get some more clarity in regard to the actual costs for state patients referred for testing at the various private hospitals? Just to use an example, for instance, from the Vincent Pallotti Hospital, has there been what is the actual subsidy, if any, been to the various private hospitals that have administered COVID-19 tests for non-medical aid patients that have been referred? And then also, what, if any, has a subsidy been for medical aid patients that have been referred for testing?
Thank you very much, Honourable Dugmore. Are there any further questions from the ANC? None? All right. I'll now give an opportunity to the EFF.
No, thanks, Chairperson. Mine is very short, man. As far
Honourable Tlego, Honourable Tlego, please proceed.
Okay, thanks.
Oh, you on mute?
Sorry, man.
We got you now, thanks.
Okay, no, mine is very short. Is on the issue of the issue of shortage of PPEs. We've received a number of complaints from the likes of Gatesville, Melomet, Gatesville, and other private hospitals with regards to high rate of shortage of PPEs. How did that impact? Just want to understand in terms of the availability of PPEs during the COVID-19 period and the issue of the shortage of staff members with regards to a number of cases that were reported in terms of them being frontline workers, and that what is the plan to avoid such kind of challenges going forward? Thank you, Chair.
Thank you, Honourable Tlego. We then move on to Good. Honourable Heron, do you have any questions?
Yes, thank you, Chair. My first question is about the testing volumes within private hospitals, and if we could get some information as to whether these volumes have changed. Has there been a reduction in the number of testing requests or patients arriving to be tested at private hospitals? And if there has been a reduction, are the private hospitals taking into account the Western Cape's new testing protocols that I think were introduced on the 1st of June, where there were requirements for public testing that had to be met before testing would take place? Mr. Costa mentioned pressure easing from July, and I wonder if the private hospitals can give us an indication of their experience of the pressure in the hospitals over the last few months, whether there was a period when the private hospitals were indeed under pressure for bed space. And then finally, just in terms of the testing protocols that private hospitals have been implementing, my question is what happens with a private patient who is tested positive? How does the private sector then connect with the public data system in terms of recording that? And then what protocols does the private hospital, the private healthcare provider follow in terms of advising patients about contact tracing and the availability of public quarantine and isolation facilities? So how does the private healthcare provider connect with the public facilities and the need for public data? Thank you.
Thank you, Honourable Heron. We will then move on to the ACDP. Honourable Christians, do you have any questions?
Thank you very much, Chair. Yeah, I will. I've got a couple of questions. Just also to talk about the costs of patients at private hospitals that was referred from the public hospital to the private hospital that does not have medical aid. Is there additional cost for such a patient? There's no place in the private hospital, but no fault of their own are referred to the private hospital because of capacity in the public hospital. What is the additional cost for such a patient that does not have medical aid? Another question, Chair, is we believe that in the Western Cape we are now peak, and August still in our peak. Now we know that there's extra capacity in our the field hospitals and all of those things. The question that I want to ask: do the private hospitals see a reduction in patients because of the infection rate, hospitalization being lower, or is it because of the public capacity, in our public hospitals is bigger than before? And maybe just another question is the outsourcing of doctors and nurses. I know that the doctor said that there is a shortage of nurses, especially when it comes to specialized skills. Is there maybe agreement with outsourcing of from the public or to the private, and from the private back to public, where you see shortages? Do they have that type of cooperation or not? And Chair, I want to also echo what you were saying. I'm very encouraged with the good reports that we've received with the National Department, Provincial Department, and private hospitals, how they work together. So the question there is, are they discussing, and I think I heard that, are they discussing post-COVID-19 collaboration between public hospitals and private hospitals after COVID-19? Are they talking about how can they maybe assist one another, and also where we don't have space when it comes to other illnesses, where there's no space in public hospitals? Is there that type of talks working past COVID-19? Thank you, Chairperson.
Thank you, Honourable Christians. I don't believe that we have a representative from the Freedom Front Plus in our meeting today. Honourable Murray, are you here? Just checking. I didn't think he's on the line. All right, I think that then concludes the round of questions from the members. I know it's quite numerous, so if you do need one of the members to repeat, please feel free to ask them to repeat the question. Dr. Volodia, then I'm going to hand over to you for the responses. Thank you.
Thank you very much. Sure, I wish I could write faster, but I might take up the opportunity for certain questions to be repeated. Okay, in terms of the questions that we've received, if we could just start with some of the questions from the DA. The first question, have hospitals experienced delay in testing? Can I perhaps ask one of our clinical people to take that question? Dr. Anshin Lopsha, would you like to come in? You're still on mute.
decided just to join the club, the Mute Club.
Welcome.
Good afternoon, everyone, honourable colleagues and all my colleagues from HASA as well. So in terms of the question posed around the experiencing of delays in the timeframes of turnaround times of labs, we certainly have experienced throughout the unfolding of the pandemic different timeframes across all different provinces, and specifically in the Western Cape, there was a time where the timeframes were quite prolonged. So in terms of our protocols, our respective hospital protocols in terms of pre-admission testing requirements, we usually required a time frame of 48 hours pre-admission for a test to be conducted with mandatory quarantine until admission, but it was experienced that these timeframes are not always met. But what I can say is that from our private laboratory partners, Lancet, Ampath and Pathcare, we've continuously been in contact and communication with them, and they've always managed the expectations so that we can translate this message to our patients and also to our facilities and doctors around what those timeframes would be. So at the moment, the timeframes are well managed and within the 48-hour period. So it seems to have stabilized at the moment. And I think to talk to the change in the protocol from the Western Cape Department of Health, that was certainly also translated to us, and we considered those changes in testing protocols, although in terms of the private facilities, we did have pre-admission testing requirements which didn't necessarily agree with the DOH's guidelines in terms of the restriction of testing, which was as understandably related to capacity constraints. So I think that answers the question about the laboratory testing. Thank you, Birin, unless there's a follow-up question.
Sorry, Anchin, while you're still there, do you want to perhaps also talk to the emergency procedures?
Thank you, Birin. Yes, sure. So also throughout the course of the pandemic and as the situation unfolded and the numbers increased and again contracted, we on a very agile basis reviewed our capacity in each hospital. Now, different hospital groups and also different individual hospitals are infrastructurally and contextually different. So broad policy decisions were taken initially at the outset, as Mr. Costa alluded to previously or earlier, about the cessation of elective surgery. And then as we've seen ourselves through the initial lockdown month or 5 weeks, another review was taken and international literature and protocols were taken into account, as was also communicated by the various academic and clinical professional associations representing medical professionals in this country. And there was an understanding that essential service lines need to continue despite and in spite of the pandemic. So there's an acknowledgement that the pandemic is not with us for a short period of time, and that the impact on other essential services such as trauma, maternity, cardiac, neurological, surgical and medical emergencies, as well as pediatrics, specifically in respiratory season, will continue to demand access to healthcare. And thereby decisions were always taken with this at the front of mind. So just after the initial lockdown period, most of the private hospital groups implemented a protocol of medically necessary and time-sensitive surgery and refrained from using the word elective surgery. So what we really prioritized were those admissions that if they were not dealt with within a certain given time frame, that they would have a negative impact on the quality of the patient's outcome. And that is how it was managed, and that is how we continue to manage it as we see the numbers decrease in some of our provinces. Thank you, Biren.
Thank you, Dr. Loubser. We have other clinical colleagues from the other groups. You want to add to any of these questions that we've just covered? If not, I'll move on to the next question. Doesn't seem so. Okay, then can we move on to the suspension of licensing? If I can specifically ask Ahmed Chauhan from Melomed to cover that for us. Ahmed, are you there?
Yes, good afternoon, everybody. Honorable Chair, good afternoon, Dr. Valodia, as well as the honorable members of the legislature. Thank you for affording us the opportunity of presenting our experience resulting from the suspension of the license. When we had our meeting with the Honorable MEC, Professor Noma French, regarding the pandemic, the first meeting, the hospitals, the private hospitals, requested that there must be serious consideration to the suspension of the regulations and licensing requirements during this pandemic. And the reason why we asked for it, and we could see the effects of it and the benefits of it during this particular pandemic, which we informed the other provinces also to follow suit. In this regard, we had a typical situation is that your critical beds required, that is your high care and your ICU, were much and are much more than you would normally have license for. For example, if you have in a hospital 40 beds or 30 critical beds, be it ICU or high care, during this particular pandemic, we've experienced that as a result of this particular suspension of the licenses, we could immediately increase high care and ICU capacity within our hospitals to 60, 70, or even more, whatever it was required. Then also what we noticed during this pandemic, which is evident right up to now, is that your pediatric wards are very, very quiet. Parents are not bringing their children to hospitals, and that is general throughout South Africa, and it's international too. So we had to immediately convert the pediatric beds for adults who required those particular beds during those pandemic. These are some of the very important benefits in the relaxation of the license regulations, and we must compliment the Western Cape Department of Health, more particularly the Minister, to take the lead in the country to suspend this particular license for the benefit of everybody in the Western Cape for this pandemic. Thank you very much. I can deal with the issue of the PPEs and Melamed Gatesville, which the Honourable Member from the EFF brought up with your permission, Biren.
Thank you. Seeing that we have you on the floor, would you please go ahead if that's okay with the Chair?
Yes, of course. Please proceed.
Please proceed.
PPEs are very, very important. As someone very leading in our organization, in the private healthcare industry, Dr. Richard Friedland mentioned in a conversation with me that there isn't a textbook, there isn't a manual dealing with this pandemic. We are busy writing this pandemic, this textbook, and we are busy writing this manual at the moment. Yes, at Melamed Gatesville, we had complaints by staff relating to PPEs. However, we must emphasize that we took the lead in ensuring that all our staff have the necessary PPEs for the designated wards in which they are in. Namely, if you notice that those working within the COVID positive areas and the patient under investigation areas of the COVID wards, which is PUI wards, they had the necessary mask, which is an N95 mask, they had the gloves, they had the necessary pullover boots, they had the overalls which were provided by us, as well as we made sure that they had a disposable overall and disposable gloves. Those working in the green areas with the patients who are not positive, in those wards also full PPEs were given, but they were not given N95 masks because there wasn't a need for them to get N95 masks because these are very scarce commodities and we had to conserve this particular thing. We had unannounced visits from the Department of Labour regarding these challenges, and Mr. Eso came there and he was very satisfied with what he saw and gave us a clean bill in regard to what he saw there, and all our protocols and our written documentation. Then we also had NAHAU, which is a major and most important union with the majority of members, staff on that particular, affiliated with that particular union, came there, they did inspection, they did a walkabout, they consulted with us, examined all our policies and our protocols, and very, very happy. In fact, they went so far as to say, can we give them permission that they can put their emblem and their logo onto our policies because they're so impressed and so happy with it. So yes, there were complaints. You'll find complaints everywhere. We're not denying it, but we have implemented all the steps necessary as required by the World Health Organization, the National Department of Health, Provincial Department of Health, as well as the National Institute of Communicable Diseases. Thank you very much, Dr. Biren and the Honourable Chair.
Thank you for that, Mr. John. I'm going to then move on to the next question about the SA Nursing Council. The specific issue there was we have a number of retired nurses who would like to volunteer in order to serve during the period of the pandemic. In order for them to do so, they have to be re-registered, what we call restoration on the register, and that was the request for that to happen, and also not to charge the fee, the registration fee for the period. That was granted by the Nursing Council. A process was then put in place via HASA, where once a week those who volunteer, those names were then submitted to the Nursing Council in order for these nursing specialists in order to work in the various facilities. In terms of the question, in terms of how do we address nursing shortages, I can perhaps ask Dr. Stefan Smuts to relay their experience. Thank you, Dr. Smuts.
Hello, Biren. Thank you for the opportunity. As indicated, one of the key challenges that we all faced, both in the private and in the public facilities, was a dire shortage of nurses, specifically in the specialized units. That would be the medical, high care and ICU units, and to some extent in the emergency centers. That's specifically where the more acute cases of COVID-19 were treated. And this was compounded by a number of the staff members that also contracted the disease and therefore had to be treated and isolated and quarantined. So we embarked on a number of strategies to address this proactively. And while as the pandemic evolved, we had to introduce many of the measures that we planned as part of our disaster planning. I think the first one was really to make sure that we have a good idea of how many specialized nurses we have, who would require some upskilling, and to provide that training up front. The second was a drive to recruit more of the specialized nurses to make sure that we offer some employment opportunities for them. Then there was a plan to upskill nursing staff that were usually allocated to areas that would actually have a decrease in workload, for instance, theatre, and then to allocate those nursing staff members into the specialized units with the appropriate training, as well as the appropriate oversight from the specialized nurses that are there. We also introduced a volunteer program of nurses that volunteered to actually come and help and contribute to the care of highly ill patients. The barrier there was that they required a reinstitution of their licensing with SANC, which we addressed, along with upskilling and a bit of training to update their knowledge with regards to the current treatment modalities. We also looked at reallocating nursing staff members that fulfilled managerial roles, either at corporate office or in other regions that were not as busy, and they were transported or transferred to facilities within the Western Cape that required support. And then as a last item on the list of initiatives, we did look at team nursing, where you would have an experienced specialized nurse overseeing a group of more inexperienced nurses to make sure that there's always sufficient nursing hands to look after the critically ill patients. And I must say, with all these plans implemented, we were able to provide excellent care to the really ill patients. That's all from my side. Thank you, Biren.
Thank you very much, Stefan, for that. If I can go then to the next question, in terms of the Bed Bureau and the role of the private sector, can I perhaps ask Andre Joseph, Andre Viljoen, who involved with the data, could you perhaps guide us there? It was the role of the private sector in the Bed Bureau, as well as the data submissions.
Thank you, Biren, and good afternoon, honourable members. The two questions around the data as well as the contact tracing was important right up front to HASA. And what we did was to make a decision that we would share all the data for the COVID positive hospitalized cases through the NICD. The NICD then on a daily basis would share this back to the provinces. As part of that sharing of data is also the contact tracing list, so that the districts or the provinces could actually follow up on that data. A lot of the reports you see coming out of the NICD is as a result of the very good cooperation, especially with the Western Cape province, and that both the private and the public sector facilities in the Western Cape are reporting into NICD. So we are really seeing a very good picture of the epidemic in the Western Cape. As far as the bed bureau is concerned, we were requested by the province to update our available beds and our available resources twice a day, 8 o'clock and 12 o'clock, onto their bed bureau. And this has been done, and I think this guides the placement of patients if there really is a shortage at one facility and there is capacity available at the next facility. Subsequent to that, HASA has designed their own bed bureau, and we will be sharing that with the province just so that we have a consolidated view of what is going on. Thank you.
Thank you very much, Andre. Anybody want to add to what Andre said? No, can I go to the next question? Chair, I hope I've covered all the questions from the DA. If I have left out anything, please just highlight it for me. I try to write as fast as possible. In the interim, may I then move on to the ANC question?
Yes, please.
Only one question. Thank you very much for that. The question was clarity on actual cost on the state patients for testing. Is there a subsidy to the state, or is there a subsidy to medical aids? Can I ask Matthew Pryor? Thank you, Matthew, if you could take that question for us.
Thanks, Brian.
Thank you.
Good afternoon, honourable members. Thank you for the opportunity. I think it's important to highlight that actual testing doesn't really fall under the ambit of the private hospitals. It is independent labs that perform those services that are often situated at private hospitals. So we don't really have a full view of either the number of tests that are coming through those laboratories, nor necessarily any information on the actual pricing of those tests or the subsidies that might be passed. As part of the B4SA work stream under the health stream, there has been some representation from the laboratories in that work stream, and I know that there's been a lot of work in terms of trying to ensure that the pricing for the tests has significantly decreased over the period of the pandemic. I think that has been achieved, but as far as I'm aware, there's no actual direct subsidy that is paid to the labs or by government for those tests that are performed in the private sector. Thank you, Chair.
Thank you, Matthew. Anybody want to add anything to that particular question from the groups?
Beren, if I can just add.
Please go ahead.
Just a little bit more on the clinical protocols around the testing. So exactly as Matthew said, that is not our operation to execute on, but there are policies made by the private sector facilities in terms of the risk mitigation strategies around allocation of patients to the different zones that we have rezoned our hospitals in terms of confirmed COVID, suspected COVID, or non-COVID. So all of our hospital groups consulted with each other as well as the private labs in making these decisions, and at all times we took the guidance from the private labs in terms of their capacity constraints, and when communication was issued from their side of restricting the number of tests that can be done because of availability, it was always taken into account. But certainly from a risk mitigation strategy point of view, we had a universal pre-admission testing strategy right after the lockdown implemented across all private facilities, which we have subsequently relaxed progressively as the community transmission increased to such a level that the prevalence was so much higher, and we upped the levels of PPE and zonal restrictions in our facilities. So thanks, Pirin. I just wanted to add that.
Thank you very much. I appreciate that. Anjan, while I've got you there were a few questions on testing from the Good Party. Would you take that as well? Are you happy to do that?
I'm happy, Beren. May I please ask that they just get individually repeated, that I just accurately addressed all of them?
Okay, I'll just summarize, and then if I've missed something, I'd like to ask the honourable members to clarify. The one is testing volumes in the private hospitals. Has there been a reduction, particularly in the private sector? And then, and why? And the other question was, there was a change in protocols in July, and what impact has that had?
Okay, thank you very much, Brian. So to take the first question about the reduction of volumes, I think it links to an extent back to the previous answer, where initially we followed the guidelines of the NICD, and as we all know, the initial availability of testing was only through the NHLS and the NICD, and thereby there were certain criteria that had to be met and were adjudicated by the NICD in terms of testing. As soon as the private labs developed the capacity or the capability to test, there was a flux of referral from from anyone who wanted to test to their GP or their specialist, not necessarily meeting the indications. The next phase of that was discerning a set of indications from the private sector hospitals, which related to pre-admission testing specifically for surgical procedures, and testing of patients who presented with either symptomatology or was exposed and had a risk exposure history. And later on, it evolved to a strategy of universal testing of everyone who came into the hospital, be it for an emergency admission or a planned admission. And one of the reasons around that was also the significance of the capacity constraints that these PUI units brought along in terms of the spatial distancing required, and the higher level of PPE, and all of the capacity constraints taken into account. Around July, the testing protocols has changed, and specific communiques from the private labs stipulated 10 testing criteria, and they all were aligned that only the first 5 of those testing criteria were going to be used or applied in terms of testing being allowed. So what they stopped doing was the testing of asymptomatic and low-risk exposed patients, and they prioritized the testing of healthcare workers, symptomatic patients, and patients in the certain risk groups in terms of age and other comorbidities. And all of that informed the changes in our protocols, and subsequently we have seen a reduction in the volume of testing as these protocols were implemented and unfolded. And I think my last comment on that was also that that we see that the community transmission had a significant impact in that. And as there was an initial surge in terms of everyone and anyone wanting to test, especially around exposure incidents in facilities, it became very difficult to track and trace what the entry point of that COVID scenario was into a facility, and thereby the testing of exposure incidents to determine whether an incident was an outbreak or not were really restricted to certain incidents, which was always guided by epidemiological input and by the Department of Health guidance.
Thank you very much, Anshin. Thank you very much, Anshin.
Thanks, Brian.
Okay, good. Chair, I hope I've covered and I've even missed any questions from the good party, but if I have, I'd appreciate if they could be highlighted. In the interim, if I could then go to the final party questions, which is the ACDP. And the first question I have is the cost of public to private. Is there an additional cost to a patient, but whether it's a public patient or a insured patient? Corné Haynes, can I please ask you to help us with that?
Thank you, Biren, and thank you for the opportunity again. So the question I have is whether there would be additional cost to a public sector patient in the private facility. Maybe four points to that answer. Firstly, the fee was set by the National Department of Health, and that fee is an all-inclusive fee per day for a different level of care. So the all-inclusiveness means that there's no additional charge to the patient for the care provided. Maybe last point there is I'd like to emphasize that this fee is below cost for the private hospital sector, which obviously is a response in solidarity with the nation and the provinces in this particular time. I can also take a second question, which I think was the last one posed, if I'm correct. It was around the volumes in private hospitals and why there's a reduction. If I heard correctly, there are various reasons. There are roughly 3 things that I can highlight at this point. The one is the private hospitals generally stopped elective cases even before lockdown. So, and that volume hasn't come back to its current level, mainly because we are under the guidance of clinicians, only doing urgent electives and not opening up the system completely. Secondly, medical cases. We saw a significant reduction there, and it's prevailing. My estimate is the lockdown, one would be compliance with lockdown regulations, patients probably being fearful of the virus and staying at home rather than staying at home. There's probably also a lack of transmission of the other normal diseases that we would see at this time due to lockdown. And then thirdly, we've seen reduced trauma also due to lockdown and various impacts that has, I suppose, positively on the health of our nation. All of those factors are still leading to a current reduction in volume and across the private sector. Thanks, Barry.
Thank you very much, Mr. Haynes. I've got two more questions. The next question, if I can move on, agreement of outsourcing of nurses where there are shortages. So in other words, are there any arrangements between private sector to outsource nursing to the public sector and vice versa? I'm not directing this to any particular person. The best who has most knowledge, could you please come forward?
Irene, I will maybe just start and then ask my colleagues to contribute. There's been no formal agreement, but as we're all aware that within the private and the public sector, many of the nursing colleagues actually work in both sectors. And many of the nursing staff actually utilize agencies to actually generate shifts that actually fit their work requirements. And therefore, they actually work both in public and in private facilities. And we did have the same experience of some of our nursing colleagues reporting that they are getting more and more work within the public sector, and others actually the opposite. So there was a sharing of resources, but not on a formal agreement.
Thank you very much, Stefan. Appreciate that. Anybody wants to add? Any other colleagues would like to add? No? Then, Chair, with your permission, I'll go to the last question. And the last question I have here is post-COVID-19 collaboration between the public and private. Are there any discussions in that regard? And also, that will it cover any other diseases going forward? I'd like to call upon Melanie da Costa, who is very closely involved with this. Thank you, Melanie.
Thank you, Biren, and thank you, honourable members. So I think that through this process, it's fair to say that we have banked a lot of lessons. I think that the most important two that have elevated or come to the top for me is all healthcare professionals are primarily interested in the best interest of the patient. That's come through very strongly. The second thing that I think has been very helpful in this process is that this engagement has really helped to bridge the divide between private and public. So I believe that there's much opportunity to carve out a new and a better future. The collaboration between the private and public sector now has shown pretty much the art of the possible. I think that there are ways in which we can leverage this national resource. I think that we have found good ways of communicating, and I believe that we can do this in a more sustainable basis. So my sense is that this would be a good starting ground in order to bring other ways of collaboration in future. That's my personal view, and I believe that's the view of the private hospital sector.
Thank you very much. Thank you very much, Melanie. Chair, if I may hand back to you, we have hopefully covered all the questions satisfactorily. I hope so. If not, please advise, and we'll try to provide greater clarity where required. Thank you very much.
Thank you, Dr. Valodia. I'm not going to invite any new questions, but I just want to check with the members whether all of their questions have in fact been answered. And if not, if you would indicate so, please.
Chairperson, it's Brett Heron.
Honourable Heron.
Yeah, I'm not sure that I heard the answer to my third question, which was about how the private health system or the private hospitals are connecting on the basis of data and the tracing and Q&I protocols with the public health system.
Yep, thank you. Honourable Philander, I also see your hand.
Thank you, Chairperson. The most prominent resource shared from private to public, please. Thank you.
So I think Dr. Valodia, you and your team have done very well if it was just those two questions that remain outstanding. So if I may hand over to you again, thank you.
Thank you very much. So in terms of the first question, our private hospitals are connecting in terms of data and tracing. Can I please ask Andre Joseph, who's close to this, to assist us?
Thanks, Biren. In terms of the data, all private hospital groups in South Africa on a daily basis submit data through to the NICD. The NICD will then share this data back to the provinces and to the districts. In terms of the contact tracing, which then leads to the isolation and the quarantining, the districts then do this contact tracing and follow up those patients. In terms of the Western Cape, the quarantine and isolation, in our opinion, has really worked well, and there's been a seamless transition from actually contact tracing into quarantining or isolation. Don't know if that would answer the question.
Thank you very much. Thank you, Andre. I appreciate that. Then to move on to the last question, the most prominent resource shared between the private and the public sector. Can I ask Dr. Stefan Smuts to assist us with that?
Thank you, Biren. Yes, I think to a large extent it was leadership and knowledge and experience and lessons learned that was probably the most beneficial to everybody. Secondly, there were specific initiatives where from the private healthcare sector, we made resources available to actually help with regards to the Western Cape call center, specifically staff members that were on duty 24/7 to answer calls. And then thirdly, there was a resource from the private healthcare sector made available full-time in the procurement arena, but that would be on a national level, but certainly on a provincial level, that was also beneficial because some of the resource flow constraints were addressed by having that resource available. But I still strongly believe it's the collaboration, the sharing of the lessons, the information, and the strong links between the different command centers that was the biggest resource that was shared. Obviously, there's always the clinical treatment guidelines and latest scientific evidence that are readily shared on an everyday basis. And therefore, we are extremely thankful to all the academic institutions that have really done excellent work in developing great guidelines that could be implemented both in the public and in the private hospitals. Thank you, Biren.
Thank you, Stefan. I think that covers the questions. Chair, just from our side to extend our gratitude for the invitation and the time spent with you this afternoon, and also an apology. I think we've run over time, but thank you so much for this opportunity. We truly appreciate it. I hand back to you.
Thank you, and our thanks go to you, Dr. Valodia, and to HASA, as well as all the representatives that were here today. Thank you for preparing the presentation and for answering all of our numerous questions. It's very reassuring to know that there are such good private-public collaborations in place. We are very clearly in safe hands, and it's also quite exciting to know that there might be some interesting future possibilities that come out of this crisis as far as it relates to private-public collaboration. So thank you very much on behalf of our committee. If you would also please send our thanks to the hospitals, the doctors, the nurses, and the frontline workers that you represent. They really are doing astounding work, and we're very grateful to them. And we wish you very well going forward. Thank you again. That then concludes our engagement with HASA today. You are most welcome to stay on the line if you wish. We are then going to proceed to have our engagement with hospital facility boards, as well as COVID survivors and their journey through the health system. But before we proceed, I think members might need a little bit of a leg stretch. So we're going to have a 5-minute, let's take it till past break, and then we will reconvene at 2:30. Please do not disconnect, but please put your cameras off and your microphones off, and we will see you then at 2:30 to start the second part of our meeting this afternoon. Thank you, members. The meeting is suspended until 14:30. We now move into the second part of our meeting, where we will be hearing from chairpersons of hospital facility boards, as well as 3 COVID-19 survivors. We will start with the hospital facility boards, and we will give each representative approximately 5 minutes to share with us their experiences in their representation of communities and in assistance of hospitals. We will then have inputs from the COVID survivors, and we will have questions and answers to both at the end. Before I hand over to the hospital boards, I would like to acknowledge them and thank them for the work that they do. They are volunteers, and they represent their communities and are the link between the hospitals and communities that the hospitals serve. So we'd like to thank them for the work that they do to assist hospitals in service of their communities. During this pandemic, something that we that we have no memory of in living memory, we are in a time of crisis, and we rely very heavily on our hospital services. So as part of our public participation process, we'd like to understand the experiences of communities at hospitals via the hospital facility boards. I'll then ask Mr. Llewellyn Jones, who's the chairperson of the Victoria Hospital Facility Board, to commence. Thank you very much.
Good afternoon. Thank you.
Good afternoon.
Chair. And thank you to the members of this ad hoc committee for this opportunity to present what has been happening at Victoria. Victoria, as you probably know, is a relatively small district hospital in the southern sub-district of the Western Cape Department of Health Structures. It is, of course, probably one of the oldest buildings. It's a historical building, but within the constraints this building applies to us and to the hospital staff, I think our teams have managed to provide excellent service to the community. The management team of the hospital certainly rose to the challenge as soon as the pandemic arose in mid-March. They formed a task team consisting of the hospital CEO together with the senior clinicians in the hospital and the key administration staff to form plans of exactly how we would be handling the pandemic and also to execute these plans. The hospital board from its side mobilized our fundraising resources to go to various previous supporters of the hospital together with some of our neighbors in the Wynberg or Constantia area. And in total, we've managed to raise just on 2 million Rand from big and small donors. I think our smallest donation was 1,000 Rand. Our biggest one was just over 1 million. With this 2 million Rand, we then could interact with the hospital task team to determine what were the most pressing requirements of the hospital that couldn't necessarily be filled by the normal Department of Health procurement channels. Our top priorities were to supplement our equipment in a couple of areas, specifically ventilators. We managed to buy a pediatric ventilator together with a pediatric intubation probe to enable us to deal with any small patients that might arise. We bought a Parapack portable ventilator, but most important, we bought 2 high-flow oxygen machines, which have been crucial in dealing with our most critical patients over the last few months. The other major item on our requirement, the requirement list was additional PPE. We certainly felt that it wasn't only sufficient to provide PPE to the staff in the COVID area, because COVID cases were popping up all over the hospital. And so we purchased additional PPE so that every single hospital staff member, cleaners, porters, and all the nurses and all the medical staff were properly protected at all times. So we spent approximately 1 million Rand on additional PPE. One of the other things that we did to make it easier on our patient community is that we installed an additional Wi-Fi capability to provide a free Wi-Fi service to our patients and to their relatives situated in the waiting areas, so that at least they were able to communicate not only with each other, but also with people on the outside. We believe this made quite a big difference to the patients. One of the services that Victoria Hospital run is called the Abundant Life Palliative Care Program, where we have for many years been providing palliative care to terminal patients and their families, so that they will be able to be looked after not only when they physically in the hospital, but sometimes after they've been discharged. Now, through this time, it's been extremely important to have these counselling services available to the relatives of the COVID patients, and especially the ones that have passed on during this time. So the Abundant Life team has been very busy. One of the other things that we've done, and clearly it's been stated before, that the hospital staff were under a lot of strain, a lot of pressure. There was a lot of anxiousness and nervousness around the risks involved. And the board has for some time paid for the services of a trained counsellor. Normally she works in the psychiatric department, counselling psychiatric patients not only when they in the hospital, but after they discharged. But she was relieved from these duties for the period, and she's been a counsellor to the staff members to listen to their problems and to, wherever possible, to intervene and make things better. The hospital has in total had a total of just under 300 admissions of COVID patients over this period. We have unfortunately had a number of deaths, and we offer our condolences to those families. Our staff have also been affected. We've had 79 staff that have been tested COVID positive in this period, but luckily there are only 8 COVID cases amongst the staff at the moment, and no deaths. Thank you for this opportunity. Be glad to take any questions later.
Thank you very much, Mr. Jones. Just shows the power of community hospital collaboration and what it can achieve. So thank you very much. Thank you to you and your board members. We'll then move on to the chairperson of the Metro TB Hospital Complex, or otherwise known as the Brooklyn Chest, Mr. Donovan Forbes. Mr. Forbes, are you on the line?
Am I on the line? Yes.
Yes, we hear you loud and clear. Thank you, sir. Please proceed.
Yes, thank you. Let me just say my name, Donovan Forbes, and both Brooklyn Chest as well as DP Marais, as many people might be aware, we're a rather unique kind of hospital in that long before lockdown, we treat patients with tuberculosis, and that in itself is a kind of lockdown. So when COVID-19 came along, we had a double dose of what we have to care for. So we are unique in that situation. And I'm glad the chairperson said that we are also just volunteers. So let me mention that in terms of our CEO, we are informed on a regular basis what happens at our hospitals, both hospitals. In fact, on our latest communication that I've had with her, there were 48 staff members that were tested, and there were 24 recoveries. And at the moment, there are 24 staff that are currently in isolation. Now, to monitor both the TB and COVID as a combination, it proved to be very, very difficult. However, we have to depend, and I'm talking about our facility board, we have to depend on our CEO together with our staff to assist us. And first of all, before COVID arrived, even at our gate, we had to sign in. we had to wear masks. And what we have continued doing that since the middle of March, we have just had to double our effort in entrances and exit for everyone. Of course, visitors are not allowed at all, and visitors were monitored long before COVID-19 appeared on the scene. I also just want to mention the problem that we have. Our patients don't come from around the hospital. They come from a country. They come from different parts of the Western Cape, and very often they don't receive visitors. Unlike some of the hospitals right here on our doorstep, you're able to raise funds from the community that you support or that support you. And that's been very, very difficult, because the communities where we are situated, very often they don't have patients in the Cape Peninsula. They come from far afield, sent here by taxi, and very often we have to provide them with ID documents and taxi fares to get home. Or on the other hand, we have to very often provide visitation and accommodation to be paid for such people. So it's unique in that sense, that we have to cater for a slightly different kind of patient, and we have to cater for a slightly different kind of community that we serve. I think that's about all that I wish to mention. It's our first opportunity in our ability to meet up with everyone, and we just hope that as time moves by, that we'll have more opportunities so that we may share some of the difficulties that we have with the broader community in the Western Cape Health Department. I thank you very much indeed.
Thank you very much, Mr. Forbes, for your inputs, and thank you very much to you and your fellow board members for all the work that you do, especially for this kind of specialist hospital and the very acute needs of the patients of those hospitals. We'll then move on to an input from Mr. Paul Bartman, who is the chairperson of the Swellendam Hospital Facility Board. Mr. Bartman, are you on the line? Mr. Bartman, are you on the line? Okay, we'll come back to Swellendam shortly. Let's then move on to the Clan William Hospital Facility Board, represented by Dr. Walter Villiers. Dr. Villiers, are you on the line?
Hello.
There we are.
Okay.
Good afternoon, sir.
Good afternoon. I'm online, but I came prepared to listen, not to talk. I'm learning from the experience of others. I don't have anything in particular to say right now, so that just shorten your time. Thank you.
Okay, thank you. You wouldn't like to make any inputs on how the hospital is coping during the pandemic?
Not right now. I would really prefer to listen. Thanks.
Okay. We'll then move on to the Otto du Plessis Hospital Facility Board, represented by Ms. Lorraine Dutoy. Ms. Dutoy, are you on the line? Are you, hello? You're on mute, ma'am, apologies. Phrase of the year.
Okay.
Okay, now
Okay.
we've got you now, thank you.
Thank you for the opportunity. I also, I'm new in this position, so I will also gladly just listen in, because I learn all the time, every day. But I can just say that the Otto du Plessis Hospital, they started with renovations and building at the hospital just before the COVID pandemic struck. And it's a bit dear macabre at the hospital now, but we manage, and I think actually it is going very good at the hospital. The community supports us very well. We had Nurses Day, and we organized for the nurses, and actually for all the staff. We had cupcakes and little cards with motivational quotes on to help them motivate. And 2 or 3 weeks ago, the local fear also came in, and they brought baskets full of chocolates, and also with very nicely and with a motivational little card for all the personnel, the staff at the hospital, just for motivation, because at that stage the numbers were climbing at a fast rate. And I spoke to them this morning. They can really see that the staff there is really motivated. And because I think that is because of the community that supports them. And they went through a rough time because they are scared, like all the frontline workers. They're scared, they don't really know what's going to happen and all of that. So we try from our side to help them do their job and show them that they're not all by themselves. I'm also on the committee. We have a committee in the town where we gathered once a week to prepare plans on how to handle everything. So everything is fine now, and I think, yeah, we can just keep our thumbs that everything will stay that way. Thank you for everything and for all the info that I can listen to and just take in. Thank you.
Thank you very much, Ms. Du Toit, and thank you to you and your board for helping to keep the staff on the front line motivated. It really does make a difference. So thank you very much for your efforts. And then finally, we'll move to the Prince Albert Hospital. We have Matron Johanna Goos here today representing the chairperson. Ms. Johanna Goos, are you on the line, please? Ms. Goos, are you on the line? Doesn't seem so. Okay, that then seems that we've had the inputs from the hospital boards. As a final opportunity, are there any further inputs from the chairpersons or representatives from the hospital boards? Would you like to make any further input? None? All right, thank you very much all for those inputs. There may be some questions a little later. We're now then going to move to our COVID-19 survivors. We have 3 residents here that are willing to share their story. And I want to say to them, thank you very much for being so brave and coming forward to tell your story. You're very welcome to the Parliamentary Ad Hoc Committee today. Thank you for your time and for sharing your journey through the healthcare system. There is an interpreter here if necessary, which can do consecutive translation. We're going to start with Chief Eric Galada. Good afternoon, sir. Welcome.
Good afternoon, everybody. All my honorable and members. I'm Chief Galada, one of the chairperson of Bontelanga, the 2 hospitals that belongs to, one belongs to province, another one belongs to the municipality, that is Langa. As an active chairperson of health committee, I couldn't believe first when after we were doing a door-to-door screening and testing into our community hall, into our township. The door-to-door that was led by Yvette Williams, one of the officials from the province. And then afterwards, just, you know, because I was not in contact that much with even people or patients, I was just opening, knocking into the door, do the introduction. Somebody will stand inside the house and then I'm outside. Then, right, now what had happened to me now? Because the knife it just bent into my hands. I just felt that I had a mild headache from my back, and I was not that lazy or feel numb, anything. But the second issue that I just got it into my when I'm at home, I find it out when I'm eating even like meat, I don't feel the smelling of food that I'm eating. But at the end of the day, I just said it can be just symptoms, of the COVID-19, because here in Langa also, I'm one of the members of the Langa COVID-19 local command center. Now I decided to go and test in Claremont into a path care. After 3 days, I was fit. You never believe it. I was just fit. Then when I received through my phone, I found out I was positive. Wow. Then I decided to just quarantine into my house. Lucky enough, into my house, only 4 people that were staying to my house. It's me and my wife with my 2 children. And then I was just isolated myself into my bed. I was not sharing any toilet or bathroom with my members at home, like my wife or my children. But at the end of the day, what you never believe it, even my 2 children, other one, my son is 13 years of age, the last one is 4 years. And then after they discovered that I was positive, and then we decided as a family that they have to go and test also. And then when everybody went to test, my wife and my 2 kids, then we find it out my wife was negative. Be aware that she's been with me every day, is sharing one bed. She was negative, and then my 2 little boys, they were positive. They had to quarantine into their bedroom. Is where I decided to buy some games, TV, more toys, then they can play into their bedroom. Meanwhile, we were on isolation. Is where I was just eating a lot of vitamin C's, medication, and then after 14 days, after 9th day, I find that when I was recovering, I find that I'm getting fit, because after I've been tested positive, I think it's because of stress, and then I just became weak. Then into my bedroom, I've got 2 huge mirrors. I was just doing a lot of exercises, sweating there. You understand? When my wife, she's the only one who was entering to my bedroom, and then she's the one who was bringing food. And then when she saw me that I'm sweating into the bedroom, thinking that it's part of the science of the COVID, then she found it out I was on a gym. That's the only thing that I can say. My 2 children, meanwhile, they were on isolation also for that 14 days. No symptoms, nothing to them until they finished their 14 days. Then I went back. I'm back on track, guys. I'm the one who's doing awarenesses to our community in Langa. Then that is what I can tell you. Nothing bad, nothing, nothing more that I can tell you, because respecting, I find that people, we have to wear mask wherever you go, because this COVID pandemic, it doesn't have, it doesn't choose person who's rich or who's poor. It can catch you anywhere, anyhow, right? That is what I can say, guys, in this 5 minutes. Thank you very much.
Thank you very much, Chief Galada, for speaking out and for sharing your experiences of COVID as a COVID-19 survivor. We will then, I'm not sure if we have Nosisi Jacobs on the line. Note that she did have some issues connecting. Nosisi, are you on the line? Ah, there you are.
Hello, I'm on the line.
Hello. Wonderful. Please be welcome. Thank you very much for being with us today. Can you hear me?
Yes, I can. Thank you very much.
Thank you very much for being with us here today, and thank you for sharing your story with us.
Oh, okay, you are welcome.
I believe you're going to share your story in Xhosa.
Yes, I prefer.
Okay.
Like to
if you
speak
could,
in Xhosa.
we have a translator. So if you just pause every now and then for our translator to then translate for us. Thank you. Please go ahead.
Okay. Okay. So must I go ahead?
Yes, please.
Igama lam nguNosisi Jacobs. Ndihlala kwaLanga. Ndiye ndatesta positive. I think it was 2 months ago. So ukufumaneni kwam uba ndiye ndapositive ndaya kwii-facilities ze-government because bendisoyika ukuhlala ndedwa apha endlini because into yokuqala eyafika kum kukuba ukufowunelwa kwam ngugqirha wandixela uba ndi-positive ndaqomba yho hayi ndiyabhubha namhlanje mntakabawo. So ndaqomba into yokubana mandithethe nogqirha wam ndifuna uya kwile nto uza kwiindawo zokwarantina ngoba soze ndikwazi ukwarantina apha endlini. So ke ngoku ugqirha wam wandenzela ezo arrangement zinjalo for uba ndiyokwarantina kwii-facilities zika-government. So kufikeni kwam phayana kwaye kwabhetere.
Sorry, ma'am, can we just stop there for a moment? I just want to give the interpreter an opportunity to translate.
Thank you, Honorable Chairperson. My name is Nosisi Jacobs, and I'm from Langa. 2 months ago, I tested positive with COVID-19, and I was sent to government facilities through my doctor, who find out that I was tested positive on COVID-19. When I was sent to these government facilities, I was very worried and very scared about my situation. Thank you. Nosisi can proceed. Can you hear me, Chairperson?
Yes.
Nosisi can proceed. Thank you, Chairperson.
Hello?
Yes, hello. Please carry on. Thank you.
Okay. Okay. Okay.
Okay.
So apho ndiye ndahlala khona kwezi facilities ke for 14 days. And then after ndaphuma ke ndirayithi. So ndiye ndancedakala kakhulu ke mna kwezi facilities andizuthi because akho nto ndiyityileyo mna ekuhlaleni kwam phayana. Ndiye ndahlala nje ndisitya nje ukutya okuziswayo phayana okuzakha mzimba. So yeyona nto endincedileyo mna bengenazo ezi remedies zenziwayo nezi mixture. So ndiye ndaphuma ndirayithi ndingabi kwahlaba nabantwana bam kuba bendikunye nabantwana bam phaya. Bona ke ii-results zabo bezingekafiki but zifike sendilapha endlini kacaba ba-negative ke babe-negative ke bona. Nisekhona?
Can I proceed with translation? Okay.
Yes, please.
I stayed in these facilities for 14 days and without even getting any medication or any concussions there. Within that 14 days, I felt very well. Even my children were there. They were quarantined with me, and it was found out that my children were not positive with COVID-19. I was just well and healthy like anyone else. Thank you. You can proceed, Mrs.
Okay. Eyona nto eyandivuyisa ngamandla ekuphileni kwam because I think before nditeste positive, 2 weeks before nditeste positive, benditeste positive kwi-TB. So bene-infection apha kii-lungs. So
What made me very happy is that within 2 weeks I tested positive with TB first before I tested positive with COVID-19. Ungaqhubekeka nosisi. Nosisi. Ungaqhubekeka nosisi. Can proceed nosisi.
Seems like we might have a connection problem.
Within that 2 weeks, before I tested positive with COVID-19, I tested positive with TB. Nosisi can proceed, please. Nosisi, can you hear me? Honorable Chairperson, can we hear me?
I can hear you, but I think Nosisi might have some connection problems.
I think Nosisi, yes, Honorable Chairperson, I think so too. Thank you.
Okay, we will try and get her back on the line. I'll just ask our procedural officers and IT if they can assist to get her back on the line so we can hear the rest of her story. In the meantime, then, I'm going to welcome Danny Olin. Danny, are you on the line?
Yes, I am.
Good afternoon, Danny. Thank you very much for joining us and for sharing your story.
Thank you. My name. Actually, what happened is at first I had the appointment of it stops because I take some grandpas, then it stops. I start getting hot during the night when I was sleeping. It comes on, off, but I was sweating very much. Then from there, I start coughing. After some days, I start coughing now. Then I said, this is too much. Let me go get tested. I go tested. Then they said to me, the result is going to come after 7 days. In the process of waiting for the 7 days, I didn't manage to get the 7 days and I didn't get to get the results. Then it struck me very hard now. I couldn't see. I was seeing dizzy in my face, in my eyes. So I had to call an ambulance. The ambulance didn't come. I called in the morning. It didn't come. I called in the afternoon. No ambulance. I called during the night again. No ambulance. The following day, it was a Sunday. Then we had to call somebody. So she took me to Retreat Day Hospital. She works also in the department of ambulance. I'm not sure exactly which department where she is, but she managed to help me. That is one of my pillars who give me the life back. From there, they check all the blood temperatures at Retreat Day Hospital. They put me on oxygen. From there, they tell me, no, we can't manage to help you here. We're going to go to Victoria Hospital. The time I get to Victoria Hospital, it was a matter of, I can say 3 hours I was at Victoria Hospital. They just assessed me and they said to me, we can't, this stage you are, we can't be able to assist you. We have to take you to Grootes Hospital. They transferred to Grootes Hospital. I get there, I think it was around 11 during the night. So they put me in the ward for the assessments. After that, I don't know what happened. I was blank. They take me everywhere. They take me until I wake up. I was in intensive care unit. So from the intensive care unit, I slept there for some days. I'm not sure how many days. And then the time I wake up, I was feeling a bit better now. I was on the ventilators, all those things. It was on me, and they had to do an operation on my throat to help me start breathing, all that to retrieve myself. I wasn't responding to anything. After that, then the time I was up now, I couldn't talk because they operate me. It was miserable to me. I was trying to find out what's going on with me. I don't know where did my voice goes until the doctor tells me, don't worry, we did do an operation on you. So we have to do something on you so that you manage to talk again. I could hear what he says, but for me to answer back, I couldn't talk because the voice was gone. I was just doing the sign language, but I can't do it. I was just trying my best. So after that, now they managed to put a thing on my throat. Then I managed, they tell me everything I must do. You must close if you want to talk. You must do this if you want to do that. Then I managed to cope it. So from there, it was getting better now. But during that time I was there, I was stressing very much, thinking if I did die, what I was going to do, all the story was coming into my mind. But they managed to calm me down, everything, and it went well. The time they take me out from the ICE intensive care unit, the nurses in there, they were telling me now, what has been happening in there until I go to G13, G12. That is where they put me for getting my oxygen and recovering in there. So I stayed in there for, I think, a week in there. After a week, they said, I know at least I'm okay. I managed to get the oxygen back onto normal level because it was getting 40, 55. I couldn't breathe on my own. So with the help of ventilator and the oxygen, I managed to cope up with the breathing system, and my lungs, it was too weak to keep the pressure. So after that period, they discharged me. I come home for 2 days. Then they said, no, it's wrong. You wasn't supposed to go home. You're supposed to go for quarantine. Then they take me to quarantine for, after 2 days, they send a taxi to pick me up. Then I go for quarantine in Blogo Hospital in Milnerton. So I stayed in there for a week. After a week, that is when I come out. But for now, I'm feeling better. I'm recovering at home. I only got some bed sores behind my knee, my heels, but it's something which is going to get healed as time goes on. At the end of it, I'll say thank you very much to all the people who stayed by me, especially the doctors, all those people who giving prayers for me. I thank them so much. I think that's it. Hello.
Thank you very much. Thank you very much, Danny, for sharing your story. Before we move on to some questions, I just want to see if Nosisi are you back on the line?
Yes, I'm back.
Great. Sorry, we got interrupted. I think we had connection problems.
Yes, I'm back online.
Thank you. Would you like to carry on, please?
Can you hear me?
Yes, we can hear you.
Yes, Nosisi.
Okay. Ndibuyele ke ngona ndiyikhwarentile kwezi facilities. Unobangela ukubana ndiyokhwarentina phaya. Kacaba into yokubana andizukwazi nokhwarentina futhi apha endlini. Ngoba kaloku yayiseyaziwa ngongumphakathi ukhona oyibona wayisasazayo into kokubana ndi-positive. So ke ngoku kafuneke ndimkile because abahlali bebeshawutisa bethukisa kunzima apha nje ekuhlaleni. So ke ngoku into eyenzekayo ke ngoku ndafonela ugqirha
Kana manetwa kwidza inayo mozodzoka inayo.
Can I ask for other participants to please mute the microphones if you're not speaking? I'm just going to ask if we could have a translation of what Nosisi said, and then we'll get back to you.
Okay, the translation will follow now. The reason why I had to go to the quarantine is because the people in my community did find out that I'm infected with COVID-19. And then my community, the people became very, very scared that I might maybe dangerous in terms of their health, and they started shouting and all those things, then it made me feel uncomfortable not to quarantine at home. So I better prefer to go to government quarantine facilities. Thank you. Nosisi can proceed.
Thank you, Nosisi. You can carry on.
Okay. 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 So ndaya ke kulo facilities ngenxa yaloo nto kuba kakucaca into yokubana ngoku kulani uba umntu encedwa because kaloku mna ndingumntu ongenafemeli and ndihlala nabantwana bam bathathu qha. So kacaba kwandiza uncedo nangabamelwane aba bandaziyo phofu. Ukutya kacaba ayisawulamba mntakabawo because kaloku nangoku ufika le nto yale ambulance kakusekugcwele kuvidorizwa kuthethwa izinto yandigqiba ke ngoku sendingekho sendimkile sendithathiwe iambulance ke ngoku kaveza uba endlini yam kufakwe itape eyelo ngamapolisa yangathi ngoku ubhubhe umntu. Uyeva ke ngoku ndayibona Facebook ke ngoku loo nto leyo kufakwe Facebook ii-social media ziyazi ngam abanye besithi ndibhubhile kugqiba uhamba ibox ngenxa yalaa tape yafakwa ngamapolisa. So ke ngoku yenye nje into eyandenza nje ndarongo because kala amapolisa ngabantu abafana uba bayasiprotecta nangabangabantu nabo bayogqibeza ngofaka itape eziyelo ongathi ngoku xa une-Covert mntakabawo uyi-criminal. So yandivisa kabuhlungu gqithi loo nto leyo but ke ndahamba ke ndayoquarantine. But ke kanzima ke ngokuba kakufuneka lo ndibuyile 14 days ndigqibile. Ngoku ndiyoyika ubuya because kaloku ndingulo ushiye apha kuku abantu bengandifuni baxa begqithe endlini yam abantu bagqume ile ntusi impumlo bahambela ngaphaya kwendlela abafuni nojonga ngapha abafuni abantwana bam ecaleni kwaba bathi abantwana bam bazasulela abantwana babo nge-COVID. Uzawutranslate sis?
Okay, thank you, Nosisi. The reason why I had to go to the quarantine facilities is because I don't actually have a family. So I'm staying only with my 3 kids. And I saw the reaction within my community when the people did find out that I'm infected with COVID-19. They started treating me bad. They didn't even want my children to play with their children because they said my children will infect their kids with COVID-19. Even the treatment, what made me very sad, even the treatment from the police was very bad because they put that yellow tape around my house when they found out that I was infected with COVID-19. And when the ambulance came there, the people were starting shouting that they don't feel happy and comfortable and safe around me. Even when people walk past my house, they don't want to walk next to my yard or my gate. They want to walk on the other side of the street because they're scared that they might get COVID as well. So I feel very bad about the way people think about COVID-19 and the people's assumptions in terms of COVID-19 because they treat you like a criminal, which is something very bad. Even the police, they make it even worse putting that tape around because I'm not a criminal. I don't feel like I'm a criminal if I've got a COVID-19. So that thing causes a stigma and it's a very painful situation that I'm in. Thank you. You can proceed, Moses.
Enye into ke ngoku ndifuna uyitsho because ke ngoku ndihambayo abantwana bam ndabashiya ngemva kuba besithi abantu beambulance abantwana bazokwazi ukukhwela eambulancini kafuneke ndishiye abantwana bam ngemva eyayiqonda abantwana kufuneke behleli nomntu akho mntu ufuna uhlala nabo ke ndabashiya bodwa endlini. Ndancedwa ngoogqirha basesomasethu ukuze into yokubana bazothatha.
Even my children, I have to leave them behind when the ambulance came to fetch me because no one wanted to help me to take care and look after my children. And then the doctors from the hospital, they had to send people to fetch the kids. You can proceed, Mrs.
Okay. So they bazobathatha abantwana babasapha esibhedlele kulapho ke baye bathestwa nabo. but ke zabuya ii-results ke sesibuye nakuloo quarantine but be-negative bona. So ke ngoku into endifuna ukuyitsho mna yeyokubana lena yokubukula abantu abane-COVID hayi ayiyo, because namhlanje uyabukula ubukula umntu ose-next door kwakho one-COVID. Ngomso awuyazi le COVID izawulala kuwe. So ndiyacela nje umphakathi nje akhe kusapotwane, makusapotwane bethunana. Ndicela kusapotwane because kaloku nawe ngala mzuzu ukuthiwa upositive unid support ngoba uva kabuhlungu, awuyazi noba izakwenza ntoni le COVID, and uyabona noba yava kuthiwa iyabulala abantu. Imagine ke ngoku mna ndathi ne-underlying sickness, ndandiqomba nyhani ndandinid support, nothi laa nto ndayenziwayo ngumphakathi. Nda-abhuyuzwa ngabantu bakalanga, andifuna uxoka, abandiabhuyuza abantu kwaba nabasesitratweni sam, kafika nabantu bakomagugu lethu because of i-social media. Ndabhuyuzeka gqithi, and andiyithandi indlela endatritwa ngayo ngumphakathi wam, ngokungathi abandazi ndawugqiba uzalelwa kalanga. Ungalentuza sisi.
Enkosi Nosisi. Even my kids were taken from home to hospital where I was quarantined in this facility because the kids had to be tested to find out whether they have got COVID-19 or not. Fortunately, my kids were tested negative. And I would like to have a special plea to the community at large. The people of Langa, they treated me very bad when I was tested with COVID-19. There were a lot of people who came around there, even from Kukuletu, talking bad about me, which is they stigmatized the situation, which made me feel very bad. I would like to ask the people to please work together with people who are tested positive with COVID-19, not to treat them like strangers. Let's work together and support each other in this situation, so that we can move forward and find solution to this problem instead of laughing at each other. Because I can laugh at someone here or laugh at someone next door. I don't know what will happen to me one day. So let's please work together to find a solution and to fight this pandemic. Thank you.
Thank you very much, Nosisi, for sharing your story. It's very clear that stigma is very real and a big concern for many people that have tested positive for COVID. And so we thank you for being very brave and coming forward and sharing your story with us today. We're very grateful for it. We do have a short bit of time where there is an opportunity, if any of the members do have questions for either the hospital facility boards or to our 3 survivors that are on the line. If members do have a comment or a question, if you just raise your hand, please, and we'll try and keep the inputs brief so that we'll be able to have our meeting on time. I'm going to start with Honourable Mackenzie.
Chairperson, and thank you for the meeting. I just want to say to the Chief, thank you very much for sharing your story. And now that you're back and are you able to smell the meat and enjoy the meat? And then did you get, when you were at home, if you got any support from the Department of Health? And to Nosisi, thank you for sharing your story. We really need to do as the committee look at what we can do to deal with the stigma around COVID-19 and any other diseases out there. So thank you to you and Mr. Olaine for sharing your story. It's really appreciated. Thank you, Chairperson.
Thank you, Honourable Mackenzie. I'm then going to see Honourable Trejo.
Thanks. Mine is on the experience that was shared by Mr. Olaine regarding the long wait of ambulance. If the department would take note of that, the period that was narrated here, of how long he waited for a day up until very late without getting any assistance. Some people might result in unwarranted and unnecessary deaths. And then on the issue of Nosisi, I think she went through a very traumatic exercise. I strongly believe that through the Department of Health, if they can be able to liaise with the Department of Social Development. She might definitely need some kind of counseling so that what trauma she went through, she should be assisted in terms of that. I know community harassment is a serious challenge, especially if you are far away from your kids, you're fighting for your life, and you don't know what is happening with your kids. So she went through a very terrible experience. But to all of them who managed to survive, we need to...
I'll recognize you in a minute. I'm going... Did you want to ask?
I don't have a hand. No, I don't have a hand, so I'm just putting in. I see I'm in as a guest, so I can't raise my hand.
Okay, thank you for letting me know. I'm going to see Honourable Philander, Honourable Lekker, and then Honourable Christians.
Thank you very much, Chairperson. Has the facility boards made any recommendations in terms of facility management and health response to the health department during this period? And has any information been forthcoming to them to enhance smooth operations at these facilities? And also, Chairperson, how has the boards been updated on progress and operations during this pandemic period? And then, Chairperson, also to Sis Nosisi, I think it's shameful and disgraceful for what she has to go through. And I hope really that practices are stopped. And I would like to know from her, how did she overcome the stigmatization once she got home? And as a woman in a quarantine facility, what was her experience, ultimately her overall stay within the facility? Thank you, Chairperson.
Thank you. Honourable Lekker.
Question.
Thank you, Chairperson. First, let me just say that to the 3 survivors that appeared before us today, that we need more people of their stature. Indeed, the community out there lacks understanding and empathy. But moreover, Chair, I'm really encouraged by their will to survive and not to perish due to COVID-19. And maybe part of what we should be doing as the ad hoc committee is to encourage communities, including all public reps out there, to do public education in our community so that people can be taught not to stigmatize, not to isolate, but hug those who need an ear to. Then the second one, Chair, is just on the second matter that was raised by Member Philander on keeping the board members up to date on any activities. I thank you.
Thank you. Honourable Christians.
Thank you very much, Chair. Just in short, I think this meeting was exceptional because of the inputs that we could hear from survivors, but also from hospital boards. And as some of the other chairpersons said, that they're sitting and listening to the others and learning. And, you know, if I just look at the Victoria Hospital Board, Mr. Jones, as he said, that they went out to go look and they raised 2 million to see how they can help. So that's very inspiring that, you know, some people, they don't wait on handouts, but really, and they went so far, PPEs to all staff and patients and the Wi-Fi. So I just think, Chairperson, we must commend him and the board for that. And also the other areas, you know, but that stood out for me. Just the other thing that's important is the 3 survivors. Now you can see when you hear listen to them, you can hear that the COVID affected them differently. And I'm just thinking of Danny, where you know COVID hit him severe. So I just want to hear from him how much, you know, physically you're okay, but psychologically, how do you overcome this virus? Because I think the virus also, when people hear that they've got the virus, it's almost like they die down and out and think I've got the virus, I won't overcome. I heard of people saying that, you know, when am I next? Because when you lay in hospital and you're there and you're critical, you see the black bags leaving hospital. So psychologically, how did that affect him, and how did he overcome and being so positive and today to tell us how he overcame COVID-19? Thank you, Chair.
Thank you very much, members, for your comments, your messages of support and thanks, as well as your questions. So I think then if we could very briefly allow for some response. Let's start with the hospital facility boards. Is there any representative from the hospital facility boards that would like to answer the question on information flows from the hospitals and the other questions posed by Honourable Philander? I see Mr. Jones, please proceed.
Yes, thank you for the opportunity. The Minister, the MEC office, there's a gentleman there, Mr. Summers, and he has formed a WhatsApp group which includes many of the members of hospital boards across the province, and they issue daily reports both in terms of the situation in the Western Cape and the situation nationwide. And there are other pieces of information that come out to at least make sure that the members of the hospital boards are informed. As board members, we haven't had an opportunity to interact directly or indirectly with the Department of Health officials in terms of giving feedback to the department. I'm sure that opportunity will come when the pandemic has passed, or when it is at least not as active as it is still at the moment.
Thank you. Thank you very much. Then I wonder if the interpreter could perhaps translate the questions for Nosisi.
Yes, Honourable Chairperson, I'll do that for Nosisi. I'll translate.
Sorry, my apologies. Sorry, I didn't see Ms. Tron's hand while we're still on the issue of hospital facility boards. Ms. Tron, please proceed.
Can I translate for Nosisi, Honourable Chairperson?
No, I'm just going to wait for the representative from the hospital facility board. I didn't see her hand. Please excuse me.
Hello.
Hello. Is that?
Mr. Arnold, Helderberg Hospital, Chairman of the Board.
Sorry, which hospital are you representing, sir?
Helderberg Hospital.
Helderberg, thank you. Yes, thank you. Please introduce yourself and proceed. Thank you.
My name is Adley Arnold, Chairperson of the Helderberg Hospital Board in Somerset West.
Thank you. Please go ahead.
I just want to say that regarding the COVID, Helderberg Hospital, it's a very small hospital, got 180 beds, but the board is on a daily contact with the management of the hospital, and the hospital informed the board what is transpired at the hospital. So we are up to date what is going on regarding our COVID patients and the running of the hospital. I must say that the management, CEO and staff is currently doing their best to assist the community out in Somerset.
Thank you very much for that input. We'll then move on to the questions. Zoleka, over to you. Thank you.
Thank you very much, Chairperson. These are the questions from Honourable Leke to Nosisi Jacobs. Nosisi, are you online? Nosisi? Okay, Mamela. All right. Honourable Leke. Nosisi, Yandiva. Nosisi, Yandiva. Okay, ke Mamela. All right, Sisi, thank you. Honorable Leke ufuna ukuqonda apha kuwe uba ingaba kunjani ukuhlala kwezaa ndawo ze-quarantine. I-experience yakho amava wakho uhlala phaa uhlala njani, indawo enjani phaa? Umbuzo wokuqala utsho uhleli njani, yindawo enjani ngokuyibona kwakho uhlala kwezaa ndawo uyaqonda ze-quarantine. Owesibini ufuna uqonda uncedakele njani kule meko ubuyiphila phaa ekuhlaleni yoba abantu bekucaphukele uyaqonda kube kule uba abanawusondela kuwo. Uye wancedakala njani uba iphele loo nto, into ziphindele zibuyele kwimo yesiqhelo? Uvile ke sisi imibuzo emibini ne? Uyivile ke mntasi? Uyivile yomibini nosisi ne? Owokuqala.
Ewe ndivile sisi wam.
Yomibini mntasi. Okay, inkosi nosisi, thank you. Okay sisi, thank you.
Okay. Oh, okay, siqale ngezi facilities. Ekufikeni kwam kweza facilities, ewe ka ungena khona ubona ubunewune ubonke mntakaba balo kusehotele. But xa usowuphakathi kaloku enye into asiqhelanga, umntu akaqhelanga uhlala yedwa endaweni. Ewe bebekhona abantwana but ukuhlala la 14 days ngaphakathi ungenzi into oko wawulele isentsho uba nengqondo le yakho ayifunctioni kakuhle. Uphinde ke ngoku ube ubungumntu lo unale virus ibulalayo. Uze ngogula ke phofu awuzanga ngobumandi. So for mina from ekufikeni kwam yotsho mhlawumbi 5 days hayi bekubed shem andifuna uphosisa. Bekubed bendibona shem obumnewu nobuphamwa but bengaboneli intweni ngoba kaloku iyona nto ibisenzeka phayana. Uyababona nabanye abantu bayagula phaya, bebegula and ke ngoku awuyazi noba kwenzeka ntoni. Usikubona iiambulensi zifika ziphinde ziphume uqobo inoba kwenzeka ntoni ke ngoku bethuna because worried, you understand. But ke andifuna uphosisa ndithe abantu ke shem bephuma begoduka besibhabhayisa thina sime ezibhalcon tshini ndanethemba ndathi hayi bo xa begoduka aba into ezawuba ngeba ndingagoduki. Kulapho ndiqalise ufayitha khona ndathi no, andikhathala le ntloko ifane yama izintloko zibane zivela nezifiva andiza kulwa because ke ukansalweli mna ndilwela abantwana bam. So ke ngoku ndithe sekufuneke ndigodukile ndaqomba angaske ndingagoduka kusemandi apha kungona ndirealize uba tshini kumandi mos apha. But ke anyway ndahlala kakuhle shem after ukurealize into yokubana man no, i-COVID there is life kakhona, kukhona ukuphila kakhona ungalentuza sisi.
Thank you Nosisi.
Oh okay,
okay, you can proceed Nosisi. Ungaqhubekeka sisi unigqibezela.
Okay, gqibezela lo wesibini umbuzo.
Gqibezela mntasekhaya.
Kulo mbuzo wesibini. Okay, kulo mbuzo wesibini hey kuthe ukufikeni kwam kwi-14 days ndaqoba kufuneke ndigodukile and ke uzumamele ke babekukhona nee-calls zimane zingena ngondilapha kule quarantine. Izinto endizivayo zangaphandle babathini abantu ngam bathini ndiqomba kukhula ukoyika apha kum. Ndizawukwenza njani xa funeke ndigodukile? Ndizawuthini mhlanga laa mini siyodrothwa nabantwana bam? Thixo sawujonge kanjani? Ebesisutshiswa ngaba bantu nabethuna nkosi yam. But ke ndazixelela into yokuba kuzawufuneka ndibe positive ngoku, kuzawufuneka ndiqine ngoku. Abantu kudala bathetha abasoze baye kuthetha ngenxa yam and abantu bayithetha into ifane nawe ngqo. So ndazixelela into yokubana ndizawuqina, ndifuneke ndigodukile namhlanje, pule nto uzawunyusa ikawusi namhlanje ndisixela uba ndiyagoduka. Andikhathele uba kuzawuthi ubethwa ngezitena noba uzawubethwa ngezitena ndibe ndivula indlu yam. Funeke ndiqhubeke nobomi bam nabantwana bam. So ndenza njalo nje and abantu babebendibona uba tshini ke kuthiwa ubhubhile lona akabikho hlaba lo mntu akeneka neewashini zakhe etshayela nasesitratweni sakhe eyadini yakhe akananiksi. Bandibona uba tshini lo mntu uphila i-normal life yakhe akukho niksi. I'm sure kulapho ezingqondweni zabaye bafumanisa into yokubana hayi man there is life ngapha kwe-COVID. Ungaqhubekeka ke sisi.
Thank you very much.
Otherwise ngoku abasanditrite ngolaa hlobo benditrita ngalo, ndiphila nje ubomi bam nje kakuhle.
Okay, Ngosi Sisi, thank you. Okay, from the first question, honorable members and honorable chairperson, the honorable member Leger asked a question from Nosisi. First question was about how was the condition living in the quarantine facility. Nosisi says it was a bit bad and strange. at the beginning, because it's not nice to see yourself being isolated as a person who has never been isolated before in your life. Within 5 days then, when she was there, she realized and saw that there are people getting discharged, and then when is she gonna be discharged? And then when people are discharged, she was standing on the balcony and always thinking, I wonder when am I going home, because I cannot stand being here. And actually, this is a nice place. The quarantine looks like a hotel. But she was very worried about the virus and the infection that she was tested positive. And then she wasn't bothered about the place, how beautiful the place is. She was just worried about what's going on in her life and people around her and the other people who are sick and quarantined there, what's going to happen to her. The only thing she was thinking is to go back home. But as time goes there, before that 14 days finished, she feels that there is life after COVID-19, after being tested. A person can live a normal life. And she had the feeling that, oh, let me just stay here at this place and not even go back home. But at the end of the day, she had to be discharged and go back home with her kids. Then the second question, how did she overcome the stigma within the community, honorable members? She says that she told herself that it doesn't matter if they can ban her and her children. She didn't care whether they can stone her and her children and kill them. There's one thing that she told herself, that she must go back home. That is her home. And now, and she was also getting calls as well. What made her scared? She was also getting calls from the community while she was quarantined. That's what made her get very scared and not knowing whether she would be attacked or not. But it happened that when she was discharged, she was never attacked. She went home with her children and everything is now back to normal and everything is fine. Nothing going bad. Thank you, honorable members.
Thank you very much. And then there was also a question for Danny. Danny, the question was, how did you manage the psychological impact of COVID and having spent so long in hospital? Danny, we can't hear you very well.
After I stayed almost a month.
Okay, now we can hear you. Thank you.
Can you hear me?
Yes, loud and clear. Thank you.
Hello?
Yes, we can hear you. Thank you.
Hello?
Hello, we can hear you. Can you hear me?
Yes, I can hear you.
So there was a question about how did you overcome the psychological impact of having been so ill with COVID and in hospital?
I did manage to overcome it through the support I was getting from my family, friends, and the school where my child is going. They always give me some calls, and the doctors themselves, they were talking to me straight about it. Said, no, I mustn't worry. All is going to come back to normal. And the time I did wake up for the third time was the first 2 times I was waking up. I was too anxious to know what's going on. And I couldn't believe I'm in hospital. So they had to put me down again for about twice after the operation. So it was difficult for me. So they start taking me from the bottom, the time I did wake up, to explain to me I'm in hospital, all that. I'm there because of this. And that's how I managed to come up on it, so that I take it slowly, because they were explaining to me the reason why I'm there and what happened to me. But before that, it was terrible.
Yeah. Thank you very much, Danny. Okay, all right. So I think that then is all our questions and inputs covered. We want to say thank you very, very much to Danny, Olin, to Nosisi Jacobs, and to Chief Eric Galada. Thank you very much for coming to speak to the committee today and answering our questions and sharing your stories. You're very brave, and we wish you very well going forward. We'd also then like to thank the volunteers from the hospital facility boards for the excellent work that's being done to support the hospitals and the staff in those hospitals so that ultimately they can offer better service to communities. So on that note of thanks, we conclude our engagement with all of you. Thank you for spending the afternoon with us. The members will stay behind, please, just for some committee administration. So thank you very much. Take care. Goodbye.
Bye.
Members, we have one set of minutes that we need to adopt, please, and those are the draft minutes of the 15th of July. I believe that they have been circulated. There we go. They should be on your screens. Please check attendance. Then we move on to page 2. Any corrections or amendments? Page 3. All right, if there are no edits, corrections or amendments, can we adopt the minutes, please?
Chair Deirdre Bartman, I move to adopt.
Thank you very much. May I have a seconder, please?
Second.
Thank you. I heard Honourable Mitchell and Honourable van der Westhuizen. Thank you. All right. Okay, thank you. Then if there are any resolutions or actions, if committee members would kindly forward those on email by Monday, please. And then our next meeting will be taking place, if the procedural officers would help me, on the, is that 14th of August, is that correct?
Yes, that's correct, Chairperson.
Thank you. And that's on the theme of protection of the vulnerable. Right, members, I think we had a different format than what we're used to today, but I think it was important that we had, you know, the voices of those affected and, you know, the volunteers working with the hospitals. And I'm glad that our first meeting with our community engagement program has run the way that it did. So thank you very much to you all for your questions and your inputs and your comments and your words of support for our participants today. If there are no other items under general, are there any items under general? None? Right, then thank you very much, members. The meeting then is adjourned. I wish you all a very good remainder of the afternoon. Please stay safe and keep well. Thank you very much. The meeting is then adjourned.